Patient comes, thank you. Patient comes along and says, I'd like a skin check. So it was really, really important to assess why have they come for a skin check. And sometimes the reasons will surprise you. And we need to assess the risks of skin cancer, which are more or less the same for melanoma as they are for non-melanoma skin cancer. And then we need to identify the lesions of concern. So firstly, the lesion that concerns the patient or their significant other, and the onset, duration, and behavior of that lesion, and the effect of previous treatment. But then what lesions concern you may be entirely different from the ones that concern the patient. And I can't emphasize how important it is to evaluate the whole patient, and that a lesion in isolation can be very misleading. So what are the risk factors for melanoma? Well, the main one is the age of the patient. Melanoma can occur in youngsters, but it's very, very rare. Melanoma is exceedingly common in our elderly male population. So gender is slightly important as well, because melanoma is more common in males, especially older males. But it's very often young females that attend for skin checks, and their risk of melanoma, of course, is less. That doesn't mean they haven't got it, so it still requires a careful examination. So the risk factors aren't so much important for that day because they've come for a skin check, but they're important for your advice regarding follow-up. So you've examined the patient, you found nothing of concern. If they're old and male, you're going to get them back. If they're young and female and have no lesions of concern, you may elect to say, this is how you examine your skin, come back if you have any concerns. Previous melanoma. The official rate for a second melanoma, if you've had one, is 10%. But in the Waikato, and I have no reason to think it's any different in other parts of New Zealand, we've just done an evaluation of all the melanomas diagnosed at Waikato Hospital over a 3-year period in which we had data, and 25% of those had melanoma in the preceding 5 years. So we think the rates in New Zealand are higher, particularly again in elderly men. So if you've had one melanoma, you should be alert for the rest of your life, but particularly in that few years around, after the diagnosis of the first melanoma. Previous keratinous skin cancer is also a risk factor, but it's not as great as if you've had melanoma. Note, I am calling it keratinocytic skin cancer. Conventionally, we've called BCC and SCC, basal cell carcinoma, squamous cell carcinoma, non-melanoma skin cancer, but what a nonsense of a name that is. So we are trying to convert to keratinocytic skin cancer. Lastly, for melanoma, but not for the keratinocytic cancers, many moles is a risk factor. So people with only 1 or 2 can get melanoma, but people with lots have a significantly higher risk, about 4 times on average the risk of somebody with few moles. There is a little bit of an increased risk if they tend to have large moles. And if you are in one of these families with 2 young relatives that have had melanoma and you have the same phenotype of moles, then your risk of melanoma can be up to 100%. But these people are pretty uncommon, and you can spot them coming in the door because they have very odd moles. Sunburns. Now, we all think of sunburn as being a risk for melanoma. Of course it is. Hands up. Who in this room has been sunburned at least once? Right, we get almost, well, everybody. Everybody in the room has been sunburnt. So it's not a risk factor. We're all at risk of melanoma. We've all damaged our skin. But the risk is greater if we're fair-skinned, if we've burned ourselves frequently, and if we have red hair and blue eyes. But they're much less important risks than age, gender to a degree, and the history of lots of moles. So we've got our patient now, and we've taken a history to evaluate their risk of melanoma. And we've taken a good examination of the whole body using a good light. Now, if you have natural light, actually that's quite good for examining the skin. We don't in our clinics anymore, and we have to actually put people on beds to examine their legs because you need light coming from on top. And then I roll them over to see their legs because the light from top means you're very shadowed otherwise. And again, using the big dermatoscope. And we're just getting a general impression of the whole patient. What kind of skin lesions do they have and where are they located? So we may find our patient has many, many seborrheic keratoses, and they're a bit of a distractor because they're not malignant, they're not pre-malignant, but they can look the same as melanoma, they can look the same as squamous cell carcinoma, so we do have to look at them carefully. And patients with many seborrheic keratoses may otherwise have low risk of melanoma, but they need general regular checks because somebody's got to be looking because you can't see, the patient can't see the wood for the trees. And if they have many moles, we want to get an impression. Are these brown moles, pink moles, flat moles, bumpy moles? What is the normal for that patient and how are they distributed? And we're all slightly different from each other. Because what we're looking for is the so-called ugly duckling, the spot that looks different from all the others. And a number of studies now have demonstrated that this is the single most important recognition of melanoma and other types of skin cancers, that the spot looks different from the other spots on that patient. And that may depend on the age of the patient, it may depend on the ethnicity and race and colour of the patient, and it may be, well, usually it's very easy. Usually it's easy. Okay. So we found something that looks a bit different. And it's quite obvious. I think we can all see that even from the back of the room, that there is a lesion that looks different from all the other lesions on this patient. And we've looked at a close-up, and we've decided that this lesion does look atypical in that it's larger and has several colours and is an unusual shape. So now we're going to take some photographs and we're going to get our dermatoscope out, and we do need to clean the lens. So I actually usually use Sterigel rather than one of these, but this is in my pocket if I don't have the Sterigel, but Sterigel's everywhere these days. So I clean the lens using this, but then it smudges. So it's really important after you've used your fluid to then buff. But these things are on our desks everywhere, so not too difficult. Using a proper cloth like this is much better because it's soft and better for the lens. But on the other hand, it soon gets dirty, and really you should be sterilising it between every patient, so it's not very practical. So practical would be those things. And then we take our photo. And we've taken polarized and unpolarized views, and we may still be concerned. We may note that this lesion has an irregular structure and various features of concern. And that's the other half of the lesion, because this really is a big lesion, and we've got some strange things coming out here which make us wonder whether the lesion is enlarging, and a little bit of us is thinking, I thought that was just a seborrheic keratosis, but what's going on here? And of course, you could have a collision. So we've got an atypical pigmented lesion, and it's solitary. It's ugly, that is to say it's different from anything else. It's asymmetrical in structure and colour. Could be a melanoma. And so if we're thinking, is this a melanoma, we are looking for chaos in terms of structure. And if there's chaos, then we're looking for clues, and those nice posters will explain chaos and clues to you. Or is it a seborrheic keratosis? Because seborrheic keratoses can be large, solitary, asymmetrical in structure and colour. So we're trying to work out, well, what are the features of a seborrheic keratosis? They're warty, but not always. Sometimes they're waxy. Not always. Sometimes they're flat. They're stuck on. Well, sometimes they merge. And they have curved lines. Well, mostly they do, but sometimes they don't. So an atypical pigmented lesion, the main differential is not, is this a benign nevus versus melanoma? It's actually, is it a seborrheic keratosis versus a melanoma? And you're not quite sure with this spot because you've looked and you've seen features of seborrheic keratosis and you've seen features of melanoma and you're not sure and you've got an opinion and the opinion's on holiday or not replying. So you cut it out. And we cut it out with a 2 millimeter margin. Now that's another part of the standards that you need to be aware of. It doesn't say anything else. It says excise with a 2 millimeter margin. So lesions suspicious of melanoma, excise with a 2 millimeter margin. Or refer to someone else. That was the SEBK. So pigmented skin lesions can be melanocytic. That is to say, they're made up of a proliferation of the pigment-producing cell, the melanocyte. Or they could be epithelial. That is to say, they're made up of the keratin-producing cell, the keratinocyte. And we've got the benign ones, the seborrheic keratoses, and the malignant ones, BCC and SCC. So they need cutting out as well, of course. But there are some other things can look awfully like pigmented lesions. First are some vascular spots. So blood is red, that should be easy, and melanoma is only sometimes red, actually quite often it's red. But red can look black depending on the light. And then dermatofibroma isn't a lesion at all, it's a reactive process, but it produces a bump that can look a bit like a melanoma. So why do we need to know the difference? Let's cut them all out. Well, benign lesions don't need to be cut out. The only reason you'd remove a benign lesion is if you can't exclude malignancy, or that benign lesion is producing symptoms, or for so-called cosmetic reasons when you may replace one problem with another. Benign lesions show symmetry. They have patterns, and these patterns together produce symmetry. We need to assess the structure and colour, not the shape, to decide about that symmetry. So which benign lesions should we be cutting out or referring to somebody else, or following up, or ignoring? And it isn't always easy. It is estimated that between 300,000 to 1 million spots have to be looked at to find one melanoma. That's an awful lot of spots. In New Zealand, people own a lot of spots on their skin. Some of them have hundreds and hundreds of spots you have to look at. So it isn't easy because we don't want to cut things out that don't need to be, and we don't want to miss melanoma. The ministry is concerned that waiting time for first specialist assessment at the public hospitals is beyond a joke. Well, it certainly is at Waikato. We have the most ridiculous triage system where the electronic letters come in from the GPs in 0.0001 of a second, and then they get printed and wait in a tray for a week or so before they get into the circulation to get to the triage person who's on holiday that week and doesn't get round to looking for another week. And he decides it's not his service that needs to have the patient, so he gets redirected back to the referral centre where he gets onto the new service, and the same goes on. And then eventually it ends up in the booking clerk's office, which can take 4 to 6 weeks. And that was with your referral that occurred instantly. Now, most places are moving towards electronic triage, but we've refused electronic triage in dermatology because instead of taking 4 hours a week to do the triage, it's going to take us 5 or 6 hours to do the triage because electronic is slower in some ways. So this is a work in progress, and I hope it's not going to go on forever. But we do want to see cancer patients promptly. So the ministry at the moment is taking, oh no, actually, up until last week, it was taking comments on what people thought of their proposals for high suspicion definitions. And this is the proposed high suspicion definition. You won't be able to read it because it's very small, so I'll read it out to you. Malignant melanoma of the skin. Well, the first word is it doesn't need malignant. That's a tautology. Melanoma is malignant, so it could just say melanoma of the skin. So there are other kinds of melanoma. You can have melanoma inside your nose, down your throat, up your backside, but we're talking about the skin. Red flags, either skin lesion, so you have to have a skin lesion. See, it's really not written very well here. I helped write it. I've only got myself to blame. Skin lesion and 3 or more of the following features. A, asymmetry of shape, structure or colour. B, border irregularity. C, colour variation or multiple colours. D, now many of you will know D for diameter, but we've got rid of D for diameter. We've changed it to D for different from other lesions because we think D for different is much more important than D for diameter. And E for evolving, changing. Well, you'll only know E for evolving, changing if you have a clear history from the patient, and you all know that you can't trust patients one bit. Or you've got photographic change demonstrated, and then you probably wished you hadn't done that in the first place if you're me. Or, so you can get rid of all those, dermatoscopy of the skin lesion is suspicious for melanoma. In addition, all referrals must include size of the lesion, so we want to know its diameter in millimeters. Body location, we want to know what part of the body it's on. Digital, macroscopic image. For those of you who are challenged, that means a photograph. If available, dermatoscopic image. So there's been a bit of fuss over the photographs, but actually they've required photographs in Auckland for some years, and that's working just fine. The photography quality is variable, but practice makes perfect. If you keep practicing taking photographs, sooner or later one of them will be in focus. Okay.
Have you had any near misses for poor photographs?
For what?
Poor photographs. Have there been any near misses?
Oh, I'm sure there's been dozens. I'm sure there've been many misses, actually. Yeah, but this is for the urgency. So the urgency is high suspicion of cancer. That means that referral goes into the top of the pile. It doesn't mean that if you refer the patient without a photograph that the patient won't be seen. Providing your referral is adequate, one would assume that eventually they'd be seen, but they don't go to the top of the list. So if you want your patient to go to the top of the list, please send photographs. Now this is coming in June 2016, if it's agreed to. So this is a draft at the moment. Okay. White and orange. Which has red flag A? Hey, great. You see, these fluorescent cards are very easy to pick. Fantastic. Can you all hold up orange, please? Any of you who's not holding up orange? Good. Fabulous. This has asymmetry of not shape so much, but colour. So it's a roughly rhomboid type shape, which is symmetrical, but it's got these black spots in it. So these are macro photographs. And it would be easy on triage to say, that one looks more dodgy than that one. If you send a dermatoscopic photograph, the triage doctor, if trained in dermoscopy, will be happy that that's completely benign and concerned that this lesion should be excised because it's maybe a melanoma. And it was. Okay, red flag B is the next question. Okay, red flag B. So most of you think that the red flag B for border irregularity is this one. But unfortunately, benign lesions do have border irregularity. It's normal for them to. And actually B is the least useful of the A, B, C, D. And I'd like to leave it out, but you know, you need a mnemonic, it needs a B, an A, B, C, D. And we couldn't think of a better B, so we left it in. And so so this is smaller than this. It's only 3 or 4 millimeters in diameter, but it does have a notched border. But there are plenty, I've just changed that this morning on the plane because I realized that the previous melanoma I'd put in there didn't have a notched border. That was partly deliberate, but then I thought perhaps it's the beginning of the session, I shouldn't make it too hard. A lot of melanomas do not have notched borders, and if you look closely, most benign lesions do have notched borders. So. Okay, red flag C. Which of these has red flag C? Great, most of you are coping. Well done. Both of them do. Colour variation and multiple colours. You two, both cards. That's why you have 2 of them. Getting there. It's not going to be easy this session. So this has lots of colours and this has lots of colours. So if we say, well, what are the colours? In a clinical view, as we're seeing here, we can see several shades of brown. You're only allowed 2 shades of brown. So we've got light brown and dark brown. We've got a little bit of black focused here. And this has a light brown and dark brown, a sort of reddish tinge, and some black as well. So multiple colours is helpful. And the more colours, the more likely that you have an invasive cancer. So early melanomas may only have 1 or 2 colours, actually 2, they're always going to have 2. But an invasive melanoma, more colours are going to come in. So here's the dermoscopy. This is a nodular melanoma, 2.5 millimeters, and it's much easier to see that not only do we have light brown, dark brown, and black, but we've actually got white as well. And in this one, we have light brown, dark brown, I'm not sure about black, but we've got white and pink coming in, and maybe some grey as well. Red flag D. Now, D is for duckling. D for different duckling. Yeah, absolutely. Which of these 2 photographs can you see an ugly duckling in? Okay, so we've got the one on the left. That's easy. Here's the ugly duckling. This guy has lots of moles, but as you look around, they're more or less the same as each other. So, one of his was photographed and was this, because it was the most odd of all the lesions that man had, and clearly it's not as odd as the melanoma. This is a 2.5 millimeter thickness melanoma. Now these pictures I've just taken in the last few weeks, so these patients are presenting regularly.
What species?
Superficial spreading. There just wasn't enough space to write it all. So on dermoscopy, we see that it's very different, even within itself. The left side is different from the right side. The top is different from the bottom down there, but you can't see it. So this benign lesion is a little unusual because it has that blue bit in the middle, but it has symmetry. So within itself, it's not terribly different. So the top is more or less the same as the bottom. The left is more or less the same as the bottom. This is biology, not geometry. So we're not going to see perfection in symmetry. What about red flag E? Good, I'm very impressed. None of you put their hands up because, of course, you can't say whether it's evolved because you don't know. Very good. Okay, how about this picture? Which of these 2 lesions has evolved? Okay, some people think the one on the left, some people think the one on the right, and 1 or 2 might think both. Well, of course, lesion A is a seborrheic keratosis. And they do change, and that's a characteristic of seborrheic keratosis. If you photograph it at 3 monthly intervals, each time you photograph it will look different from the previous time. So E is not useful for seb-Ks. B, here we have a history of a lesion photographed in 2012 and photographed again in 2015. These are at the same magnification. The lesion has enlarged. So there's no question about it. E for is true. But it remains benign. So E is useful in melanoma, but E can be positive in seborrheic keratosis and benign nevi. So let's have a look at a melanoma. This is 2010 and this is 2011. These are macro photographs taken at the same magnification, and clearly the lesion is larger and more peculiar looking. Here it is. It wasn't all that peculiar in 2010, and in context, which is an extremely sun-damaged patient with numerous weird-looking lesions, that was not removed. You always look back and you say, well, why didn't they remove it then? But you have to look at it in context. And there was a lovely poster which nearly won the prize. I had to judge the posters, and there were 260 to judge. It was quite an effort. But one of them was a very good poster and was our second choice. We weren't allowed to give it to the winner because it was the president of the Congress. And he said, don't give it to me, who's the other one? So we gave it to the other one. But his poster was looking at evolving lesions, like melanoma that's evolved, and why wasn't it removed earlier? And in all cases, it's because there were so many other weird-looking lesions on the patient. But those weird ones were stable. So people with weird lesions, worth having digital dermoscopic surveillance or mole mapping to determine whether lesions are stable or change. Not necessary for people with very few lesions or normal-looking moles, if they're given skin examinations instead. Okay, so how do we detect a malignant lesion? We detect it by many reasons, but I like the chaos and clues system, and that's why you have been given Cliff Rosendahl's chaos and clues poster. We can have the light on, thank you. Now, Cliff is a GP. He's a GP in Queensland. He's associate professor at the University of Queensland. And he's worked with a number of dermoscopists, including Harold Kittler, who's from Vienna, in the determination of finding the easiest way to pick melanoma. And melanomas are chaotic. Some benign lesions are chaotic, like seborrheic keratosis, so we do need additional features to identify the melanoma. So chaos means asymmetry of structure and colour and more than one pattern. You're telling me it's time to stop, huh?
Yeah, morning tea time, yeah.
Oh, good. Well, that's good. And we'll go through these clues as the day goes on. And I'm not going to show you this slide again for a while. So after morning tea, we'll be doing mainly the clinical aspects of skin lesions, building in dermoscopy to help you determine whether a lesion needs to be excised.